Irritable bowel syndrome is on the rise, with up to 15% of people affected. That's hundreds of millions of people. So what's happening to our gut health?
Is it something truly in our water, what we eat, the types of stressors that we have in the life that we lead today? It's very challenging to pinpoint.
I'm Dr. Karan, an NHS surgeon, and in this podcast, we cut through the BS of modern health advice and tackle the biggest issues in science and medicine. Austin Chiang is a gastroenterologist, author, and well-known health influencer. In fact, he is the guy who inspired me to start my very own social media journey on TikTok. And as an expert in gut health, he shares his advice on IBS, low FODMAP diets, colonic irrigation, probiotics, and other gut hacks.
You can't predict the outcome of how you might feel on some of these supplements because they're not well regulated. There's not a predictable outcome. Some people might actually feel some symptom relief, but others might not get any benefit at all and might actually feel worse.
We also get into the worrying rise of one gut-related cancer in particular.
We're on trend to actually have colorectal cancer become the number one cancer killer among people less than 50 years old by the year 2030.
And we discuss all the hype around leaky gut.
To say that it's a disease in and of itself, leaky gut syndrome, is a non-existent entity.
As well as all of this, Austin shares actionable advice for gut health, the latest AI tech advancing the field, and the 3 things he would never do as a gastroenterologist. Sit tight. Well, it's so great to finally have you here, Austin. Really thankful that you can join me across the pond. You're a gut expert. I love talking about the gut, and I'm a surgeon myself. When I think about the gut, or when I used to think about the gut, and I think most people probably think about this as well, they think about poo, they think about constipation and bowels. But actually the gut, it's a bit of a misnomer because the entire digestive tract is more than just about the intestines and more than just about constipation and poo, right?
Yeah, exactly. It's so much more than just digestion and what goes in comes out the other end. There's also other organs that are involved in the digestive system. If you think about it, the liver, the pancreas, they're all involved in creating some of the digestive juices that help, digest our food, but also regulate other parts of our body as well. So there's just so much more to that. And we're also understanding more about the connection between the gut, the organs in the gut, and other systems like the brain, and even just general issues that are invisible, like obesity, for instance, and the role that the gut has on that, and also like the gut microbiome and all the bacteria that live within parts of our gut as well.
I feel that when it comes to digestive issues and the gastrointestinal system, we know a lot about the liver. We know a lot about the stomach and the esophagus and the intestines. And I feel that, it's all been pretty rapid developments, right? From, the 19th century when William Beaumont experimented on Alexis St. Martin and, unethical dark experiments where, he looked at a hole in someone's abdomen and kept looking and experimenting through that. Even through those unethical experiments, we learned a lot over the last couple of 100 years, but it still seems we don't really know as much as we should. What do we still not know about the gut and the organs associated with digestion?
Oh my gosh, so much. I think some of it is we don't understand the nature of how some of these diseases come about and the mechanism behind why, some people develop certain conditions. We might not understand exactly, how the treatments should be developed to treat those conditions as well. Sometimes we're not unable to test properly for these conditions. So I feel like there's a multitude of different reasons why we can't pinpoint, easy answers. But as you mentioned, we've made a ton of progress over the past century, just medicine in general, right? And if we continue that pace, I'm sure we're going to find more and more answers. And, some of these answers can be really in surprising places. The Nobel Prize was awarded a couple decades ago to the discovery of H. pylori, that bacteria that can live in the stomach. And that revolutionized how we think about how bacteria can potentially lead to cancer, which is something that before that really wasn't something people thought about. So as we explore more of these possibilities in the future, I'm confident that we'll find more answers.
It's funny you say that about the H. pylori bacteria and how, the guy won the Nobel Prize for it. And I can't think how amazing that was that Barry Marshall, who won it, decided to drink a cocktail of potentially very lethal bacteria and gave himself ulcers all for science. I mean, that is really hats off to gastroenterologists. I know surgeons love to give them a hard time, but that's pretty impressive that he would give himself a disease, a pathology, and then treat it to test his hypothesis. I mean, that is the basis, I guess, of medicine. It's still a bit of trial and error and working out what works and what doesn't work, even in this day and age.
Yeah, absolutely. And you actually brought up a really good point about the unethical trials in the past, because things just weren't as regulated back then. And I think the way we do science today, because it's so much more regulated and structured, it does tend to slow things down. And because we have understood the easier things, quote unquote, about medicine, it is going to be harder to find the details that we're trying to figure out now.
Now, one of the things that you just mentioned briefly there was the lack of understanding we have for a bunch of things and how the etiology or how disease can start and spring up in the first place. And when you mentioned that, one disease which springs to mind is IBS, irritable bowel syndrome. I guess even a matter of a few decades ago, doctors and physicians were just saying it's a case of it's all in your head, which is untrue in the sense of gaslighting the patient and saying, it doesn't exist, it's a problem in your head. Although, as we'll no doubt come to chat about, there is a gut-brain connection there. But irritable bowel syndrome seems to be something that is incredibly common. I mean, up to 10%, 1 in 10 people in the Western world have irritable bowel syndrome. Happens more in women. And it doesn't seemingly have a specific cause or a cause that we know of. Doesn't have a specific test that we can say you've got IBS based on one test, and doesn't really have any cure or treatment as far as we're aware. How often do you come across IBS, and what is your take on why it's so common?
Yeah, it is incredibly common, to your point. I think me personally, I tend to be on the more procedural side of gastroenterology, but within my circles as a field, we see it so often. And as you mentioned, it can be an incredibly frustrating experience for patients because, to your point, there isn't an exact test for it either. And so the way we diagnose this is basically ruling out everything else, and then we come to the conclusion that a patient may have irritable bowel syndrome. And so, imagine going through a battery of different tests and then being given this diagnosis for which we don't really have a great treatment for or a great understanding of. But yeah, it's very common. And to your point, we're beginning to understand that it's not a made-up condition. But there is some sort of dysregulation between that relationship with the brain and the gut. So some of the treatments that are available today are really there to control that connection and control the symptoms that people may experience, from that. But there's not a great way. Sometimes it's controlling the symptoms and kind of calming the nerves of the gut. Sometimes it's altering, the foods that we eat and identifying triggers that can potentially worsen those types of symptoms that lead to that people experience with irritable bowel syndrome. But there's nothing that really targets the underlying cause because we simply don't really know, what brings this about for some people and not others.
Now, I've found that in my experience over the years, both seeing patients in clinic, listening to people online, potentially self-diagnosing, it seems that there are a lot of people who have a self-anointed IBS diagnosis without any formal criteria. And whether it's because they've just read online that the symptoms they have some overlap with potential IBS criteria and said, okay, it sounds like I've got IBS. I've got some cramps, I've got some pain, my bowels aren't regular, I've got IBS, and certain foods flare it up. But obviously, IBS itself has some relatively strict criteria, but also it's vague in the sense of, there could be a bunch of symptoms which overlap with other things like acid reflux, gallstones, inflammatory bowel disease potentially, bowel cancer, some gynecological conditions, and so many different things. So there could be a swathe of people who have irritable bowel syndrome truly and who are misdiagnosed as something else. and actually vice versa, have something else and are misdiagnosed as IBS. So if someone is there sitting at home listening to this right now, as a doctor, as a gastroenterologist, what are the kind of very basic criteria that one must have to be considered for an IBS diagnosis?
Yeah, that's a really good point. I mean, first thing I'd like to mention is that personally, that's one of my biggest concerns is delaying another diagnosis because you're assuming that you have IBS. And some of these conditions, if you're delaying a diagnosis, God forbid, cancer or something like that, then that time is really valuable. So we want to detect things early, which is why we still recommend that you get evaluated professionally, because we don't want to miss these more serious conditions, right? But when it comes to IBS, there are certain criteria about how frequently you experience these symptoms, whether or not there's pain, whether or not the pain is relieved, with bowel movements. There are different categories of IBS, whether it's constipation predominant or diarrhea or a mixed picture. So, depending, it's not a one size fits all type of condition. And the treatments likewise are also not consistent across the board.
So basically, as you again emphasize to what you say there, it's important not to self-diagnose and actually seek a consultation so you can be excluded for those more serious things, but also try and see if you fit the criteria for IBS, because although there may not be any cures or immediate treatments for IBS, we can provide some quality of life improving symptomatic management, which could make things a lot easier, almost like you don't have IBS.
Definitely. I mean, there are definitely patients who have the diagnosis but make adjustments and can truly improve their quality of life. So it's not that your condition can't be improved. It definitely can.
So, given that we don't really know a specific cause of IBS or a number of other, gastroenterological conditions, functional bowel conditions and so many other things, and we've seen a rise of them over the years. Now, could we attribute that rise to just people being more health conscious, more better diagnostics, more testing, more screening? Or is there population and environmental factors or lifestyle factors that's causing a rise in all these GI conditions?
Yeah, I think that there's definitely both involved. The better our diagnostics are, the more we're going to pick up certain conditions, to your point. But I also feel like there are things, if you look at certain studies related to colorectal cancer, for instance, yes, when we do more screening, we're going to find more things. But outside of that, we're still seeing an effect that likely is due to environment. And what that exactly means, we don't know. Is it something truly in our water or what we eat? The types of stressors that we have in the life that we lead today. It's very challenging to pinpoint. And I think part of that challenge is also, the effects that we're seeing, once you get diagnosed could be an effect of something that happened way beforehand, decades perhaps during childhood. And things that you may have consumed back then may not be the same as what we're eating today. So it's really difficult to say exactly, what the cause is, but that's, what we're chasing after.
Just to pick up on that point you mentioned about stresses in the life and stress being one of those stressors, even individually, there's a study I came across, a 2021 study where they looked at basically 50,000 people with IBS. And they found that, people with IBS were more likely to have anxiety in their daily lives, anxiety, phobias, things like that. And actually a subset analysis of those 50,000 found that people with both anxiety and IBS were more likely to have had repeated doses of antibiotics in childhood. And that's, I guess, going back to your points about a number of things in our lifetime which could influence our risk of these conditions. And I guess just a caveat as well, the authors of this study didn't say that anxiety causes IBS or IBS causes anxiety, but there is definitely some, interconnection between a mental state and the gut state. And as this subset analysis suggested, with the antibiotics potentially influencing the nerve cell development and the microbiome, whether that has a role to play as well in all these kind of things. How big a role do you think the kind of mental state has on the state of the gut?
Yeah, I think that's a really great question. I think that definitely it affects our perception of some of the symptoms that that we may experience from these gut health conditions. So take IBS, for example. The abdominal pain that you may experience definitely could be exacerbated by stress or anxiety or other types of mood disorders that you may have, like on top of that. I will also say that there was a recent study, I think it was an animal study, that seemed to suggest that stress could also have some sort of impact on inflammation in the gut as well. Whether or not that's related to IBS, IBS technically is debatable whether or not there's inflammation involved there, but it could lead, it could exacerbate some other conditions like inflammatory bowel disease, IBD, or other related conditions like that too. But again, that's just in an animal model, so we don't know if that's the same in human beings or how we can make that association.
What are your thoughts on also, I guess, on trending topics? There seems to be this increasing awareness that there's a rise in colorectal cancer cases across the world in general, but then specifically a rise in these cases in younger people as well. And I think back to Chadwick Boseman, who had diagnosed with essentially stage 4 colorectal cancer in his 40s, which I guess back then was a huge shock. But then since then, I've seen younger people as well in my own practice diagnosed with various bowel cancers and pancreatic cancers in their younger decades as well. Why is that?
Yeah, I mean, that's definitely true. The latest statistics that we see each year show that in younger people, we're on trend to actually have colorectal cancer become the number one cancer killer among people less than 50 years old by the year 2030. So it is very concerning. And to your point about Chadwick Boseman, it was really unfortunate, but it did raise a lot of awareness, especially among Black communities, which was super important because historically, a lot of Black individuals don't get screened as much as other populations. So we're appreciative of the impact that his legacy has had. And I will also say that the trend towards younger people, in the past, I think there's been some response in the U.S. at least. We've adjusted our screening age to start at age 45 for average risk individuals versus age 50. So if you don't have a family history of colorectal cancer, if you don't have any underlying disease that predisposes you to developing colorectal cancer, like inflammatory bowel disease, you start getting screened at age 45. Unfortunately for Chadwick Boseman, that still wouldn't have captured his cancer in time. But yeah, the reason behind why this is, again, no one really knows. We think that there is an environmental factor on top of increased screening. And, I think the generally accepted response, even though, it's not true, completely evidence-based, is that maybe it's got to do with how ultra-processed the foods are that we eat today versus, what it was like in the past. And so, a lot of what, obviously with gastroenterology, we talk about, foods that we eat. And so we do recommend, trying to stick to whole foods and foods that aren't ultra processed, even though you can argue that a lot of foods are processed just to, decontaminate foods. But in the sense that, they're not sticking to foods that don't have a ton of additives and, are artificial, because those, you don't really know what's in them. And some of those substances could potentially be harmful, even though we might not know it today.
Yeah, I think that's a really interesting area of research, this whole ultra-processed food area. I mean, there was a really popular book that came out about it a couple of years ago, which certainly, I guess, highlighted and emphasized that point, but also in equal parts probably fear-mongered as well, because I don't know, like I'm sort of divided on the ultra-processed thing to some degree. Clearly, we need a lot more research into that area. But also I feel that, for example, take something which is potentially ultra processed like artificial sweeteners, right? There is some data on animal models out there which suggests that maybe it causes some disruption to the gut bacteria. But again, if you think about the type of person who may be preferentially trying to have foods with artificial sweeteners and 0 calories, they may be obese. And we know that obesity itself can disrupt the gut microbiome. So is the benefits of artificial sweeteners or ultra-processed foods better than the risk of certain conditions they might develop had they not taken those foods. So I think it's such an interesting area to just like consider. And I totally agree. We just need more data on this, right?
Yeah, absolutely. I was just going to mention that, that exact example with artificial sweeteners is that, that for certain people, some of these foods are actually really, really helpful in preventing other conditions that could actually be more harmful to them. And even if we're thinking from a cancer perspective, right? The cancer association with obesity, that could truly outweigh, any sort of cancer risk that's potentially associated with an artificial sweetener. So I think we really have to be careful. And you're right. There's that other extreme of fear mongering and reading too much into all the different additives that are in foods, that some of which are actually truly harmless.
Yeah, and I guess if we all read all those books and fear mongering news headlines, we'd just end up eating sand. Nothing
I
else.
like the meme that I gets shared quite often about like all these chemicals. Like, would you eat this something with all these different chemicals in it, and it turns out to be like blueberries or something?
Right. Everything's a chemical, right? Everything is a chemical.
Exactly.
And I think one positive that you've mentioned of increasing awareness of these things is that people are more proactive about their health, which is great. I guess on the other hand, that proactivity can sometimes in itself become harmful because we've seen a rise in the number of people going out there and thinking because of all the toxic chemicals and compounds they're consuming, it's residing in their gut, they need to go out and detox or, get a colonic irrigation, for example. And in my own career in clinical practice, I have seen a middle-aged man come into the emergency room with a perforated rectum because he went and got private colonic irrigation in some medical spa somewhere in the UK and came in with severe rectal and abdominal pain. And that sharp spray of water from the colonic had caused this injury to his intestines. And he ended up needing antibiotics and surgery.
Yeah.
And that's an extreme example. But, these sort of things like colonic irrigation are pretty unregulated for the average person. There's a role for irrigation for some disease states in colorectal surgery and gastroenterology, granted. But for the average person like you or me, if you're constipated, you don't go out and get an irrigation.
Yeah, exactly. And like you said, a lot of when we're over concerned about prevention or kind of trying to find these solutions, sometimes these preventative, therapies or whatnot, supplements, it's not that they come without risk. I think we have to be very aware that even things that are over the counter, some of these probiotics that, again, it's a very unregulated space. So people might actually feel worse. There may be additives within those that could be more harmful. These full body scans that are being promoted out there, we generally recommend against that because it might pick up things and lead to more testing and unnecessary procedures that are potentially harmful as well. And so, it's a bit of a trade-off.
You just to pick up on your probiotics point there and supplements in general, what are your thoughts on probiotics in terms of the pros and cons and the current science of probiotics and the evolving science of it?
Yeah, if we truly look at the best available evidence out there, there's very few situations where probiotics are actually recommended. And I think the reason why is because we just don't have a great understanding of what strains to use for what condition, what bacterial strains, I should say, for what conditions, at what dosage, these probiotics should be at to treat these conditions. So there's still a lot of gray area here. But to your point, it's a very rapidly evolving space. There's a lot of investment in it because people are interested. And so we might see the science change. And so we have to be adaptable to, the potential benefit of probiotics, but we're not quite there yet in really targeting, specific conditions with probiotics.
I think the last time I reviewed some of the evidence, there was some decent evidence for specific strains for IBS-D, the diarrhea type of IBS, and some, antibiotic-associated diarrheal illnesses. So very select conditions, specific strains that are medical grade, like your, colorectal surgeon or gastroenterologist might prescribe you, that could help. But I guess, yeah, for the average consumer going into a supermarket and thinking that, this peach or strawberry flavored drink or supplement is going to do wonders for your gut and is going to be a panacea for health is, I guess, a little bit far fetched, right?
Yeah, definitely. Like you said, there are certain situations like being on a course of antibiotics where you may qualify to be on probiotics. But some of these supplements over the counter, like I said earlier, people might feel worse being on them because you can't predict the outcome of how you might feel on some of these supplements because they're not well regulated. There's not a predictable outcome. Some people might actually feel some symptom relief, but others might not get any benefit at all and might actually feel worse.
And one of the, I guess, things that have been born out of social media and online misinformation in general is this condition called leaky gut syndrome, whatever they want to call it. And actually, without completely rubbishing it, there is a morsel of truth in that. When you have inflammation or gut dysbiosis or something going wrong in the gut, there is some inflammation which makes the gut leaky in some senses, right? The cells between the gut lining, they spread apart a little bit, and toxins from the blood can get into the lining of the gut and vice versa. So that leaky gut, mechanistically, it does happen. But then why, in your opinion, in fact, why is leaky gut as a diagnosis for someone completely going down the wrong path?
Yeah, I think that the gut leakiness is definitely a part of certain conditions like inflammatory bowel disease. But to say that it's a disease in and of itself, leaky gut syndrome, is a non-existent entity. And so when we're thinking about certain treatments, we're thinking about the treatments for the underlying condition that's causing the gut to be leaky. But what's being promoted out there when it comes to leaky gut syndrome as a disease itself is completely made up. And so whatever treatments are being proposed are really not meant for there's no established diagnosis to treat. So it's all a little bit voodoo. And so you just have to be really careful because, again, you might be missing out on an actual true diagnosis that's underlying that could be more severe. And if we're ignoring it or if we're mistreating it, that's only going to prolong your symptoms and potentially lead to bigger problems.
Now, this might be a bit of a open question, but I still think it's an important one. Given that, there are so many things that could go wrong with the gut and so many different organs. If you were just a concerned person about your own health, without going for fancy scans or doing all of these weird things, what are some red flag symptoms in terms of, intestinal health to begin with, that you'd want someone to be aware of to think, hang on, if I'm getting those symptoms, I should probably go checked up?
Yeah, I would say if the symptoms don't go away, first of all, then it's time to go see somebody. So if it's something that comes and goes and disappears and never comes back, then you may be able to ignore it for a bit. But if it's just persistent and doesn't go away, then you should definitely get it checked out. If it interferes with your daily activities, you're not able to function, definitely get it checked out. If you experience bleeding is never normal. So definitely get that looked at. If there's unintentional weight loss, if you're not trying to lose weight, but for some reason you keep losing weight, that's also not a great sign. If there's fatigue or lightheadedness that out of your ordinary, that's something that needs to get checked out as well. And I think lastly, I would say if you basically kind of along the same lines, if there's something that's very regular for you that suddenly changes, whether it's the consistency of your bowel movements, the shape of it, again, the color, if it's bloody, that's the time that you need to get things looked at because you know your body best. If something just doesn't feel the way it usually does, then you should probably get it looked at, just for peace of mind at the very least.
Going back to IBS that we sort of talked about quite a lot earlier on, if someone were suffering with IBS, and like 10% of people might be out there, and there might be a greater proportion of people who might be IBS and underdiagnosed or might have IBS-like conditions or kind of pseudo IBS, where they may even respond to some of the treatments or dietary recommendations that one might recommend in IBS. And typically that's the low FODMAP diet. Could you tell us a little bit more about the low FODMAP diet and how can one practically apply it in a life?
Yeah, so basically low FODMAP. FODMAP stands for fermentable oligo monosaccharides and alcohol polymers. And long story short, basically means that we're trying to avoid certain foods that could promote the bacteria in your gut from creating more gases. And the gas can lead to bloating and can lead to some of your worst symptoms with IBS. And so yeah, depending on when you're able to avoid some of those foods, the process of identifying the trigger can be very frustrating, and it takes a lot of time to figure out. But if you eliminate a lot of these FODMAPs and then slowly reintroduce them, you may be able to figure out, okay, specifically which foods are causing your symptoms so that you don't need to avoid entire food groups. But it can be a really tough process for sure.
Yeah, and I guess the best friend for someone who's maybe suffering with IBS and making dietary changes would be a dietitian or nutritionist to really guide that
100%.
process. And I remember, when I first started out in surgery, coming across a couple of patients with IBS, and one of the nutritionists who was working with the surgical team at the time really highlighted the point which stuck with me, is that a lot of people think that this exclusion is lifelong. And it's restriction for lifelong, and your life is ruined if you've got a gut condition or IBS. Even if it's inflammatory bowel disease, you probably don't need to get rid of XYZ or onions or apples or garlic for life. It just means, I guess, a transient period of either reducing the amount of those FODMAP foods, like apples and onions and garlics and all these other things, or excluding them briefly, one by one, to figure out what's the problem. And then if it's not a problem, you can slowly reintroduce it, right? That's the
Exactly.
you should have diversity, and it's not a permanent bland diet of just bread and rice and bananas.
Yeah, I think a lot of people would get a huge amount of benefit from seeing a dietitian because you don't want to be missing out on some of the nutritional benefits of some of these foods, because a lot of these, fruits and vegetables that do cause, gas production are rich in a lot of other nutrients that we could really benefit from. So the less we can exclude, the better, and that way we can reap the benefits of other foods.
Now, if someone were suffering from some GI conditions or some symptoms, would you recommend they proactively go and try to find what's wrong, try some kind of at-home treatment with some dietary manipulation, or should the first port of call being go see the doctor?
That's a difficult question. I think that, there are situations that even after you go see the doctor, the recommendation that you might come home with is to try something like excluding something from your diet as a first step, or just being on a brief trial of a medication, for instance, to help figure out, exactly what might be going on. So that initial visit might feel a little frustrating because you may feel like, oh, this is something that I could have come up with myself. But I often like to say that, if the earlier that you get a professional involved, at least you won't be led down the wrong path. But absolutely, take lactose intolerance, for instance. If so many people have that sort of intolerance to lactose from dairy products, and sometimes all it takes is just excluding that for 2 weeks as a trial and seeing if those symptoms improve. But then if it doesn't, then, we go down a different path of testing and diagnosis.
Now, you're obviously very into the endoscopic, procedural, minimally invasive intervention side of things in gastroenterology. And there's so much new research and technology coming into that. Where do you think researchers in the GI space and the gut space should be focusing their research going forwards?
Oh my gosh. I mean, GI is such a diverse space. And, there's so much that we can do procedurally through the mouth, both to diagnose conditions and to treat certain conditions. And it really depends, depending on where you think about along the gut, the esophagus, the stomach, the small bowel, the colon, the liver, pancreas, all these organs. It's become so subspecialized that there's investment in all of these areas to not only diagnose and treat conditions medically, but also procedurally in certain situations as well. So I think a lot of investment now is a lot of what gastroenterology has been built on is taking more invasive surgical techniques and trying to make them less invasive. So for instance, there are situations where early tumors that haven't quite turned into cancer yet, or even very early stage cancers, could potentially be carved out of certain parts of the gut without having to do, complete surgery or cut out entire sections of the gut, which obviously would be a much better patient experience. And then there's a lot of research as well being done in artificial intelligence and helping, help diagnose things more better, or improve our, procedural techniques, make our procedures more efficient. So there's a lot of work being done in this space.
And out of the things that have come into play in the last few years, what is the most exciting new things and new toys and new areas of research that you think really are going to make a difference, over the next few years?
Yeah, I think just like every other sector out there outside of healthcare even, I think AI is going to have a huge impact, not just in our procedural areas, but also helping discover, more medications more easily. Like I said earlier, like improving our workflow and efficiency so we can see more patients and make sure that those wait times are being cut down. And, even from a physician perspective, right, like trying to reduce burnout because there's so much administrative burden that doctors everywhere are suffering from, and it makes it difficult to work in because we want to focus on the medicine and focus on the patient and not deal with other things. And I think artificial intelligence can potentially have a great role there. But yeah, there's so many directions that AI could take. And, currently what's available out there is there's already AI that can help doctors, not miss certain things as much, like polyps during a colonoscopy, which could really potentially make a difference in terms of, reducing how much cancer develops over time. So that space is really exciting. And I think another space is, personally for me, I'm super excited about where robotics is going. There's, I think, a limitation as to like the precision that we have with our own hands. And we're not seeing robotics in gastroenterology quite as much yet, but that's something that there's a lot of buzz about within our field, at least among the proceduralists. And so who knows where we're going to be in 10, 20 years.
Yeah, both out of a job.
Or hopefully we'll still be controlling the robot.
So if I were to sneak into your house in the dead of the night and look into your cupboards, what supplements would I be able to find in general for your health, but also more specifically for gut health, for general digestive health, even not just for improving your health, but just, as a safety in case you run into some problems?
Great question. My cupboard is generally free of most supplements that people might be thinking of, but I do keep fiber on hand because generally speaking, I feel like we don't consume enough fiber as much as, is usually recommended. And so I do have fiber, which sometimes I will take some extra of just to make sure that, we keep things regular and soft and moving, because if we don't, there can be problems that arise with that too.
And the fiber that you have, is it a special type, or is it like the psyllium husk that people get?
It's psyllium husk. It's very generic. So, these supplements that actually do help don't have to be expensive, fancy things out there that are experimental. They can be very tried and true things like psyllium husk.
And now I've moved away from your supplement cupboard and you're still sleeping. I've now stuck into your fridge. What are some fruits, vegetables, and foods in there that you would use as a gastroenterologist to support your digestive health?
Yeah, I'm actually very keen on fruit. So I fortunately don't suffer from IBS myself. So I don't have many limitations with the types of fruits and vegetables that I have. I also have, Greek yogurt, which is very high in protein, but can potentially also help out with certain gut conditions and promote a healthy gut. What else is in my fridge? I have to think about. I am a coffee drinker, so I have coffee in there.
It's great to get the bowels going. Prebiotic fibers.
Yeah. But honestly, you know me. I actually have to travel a lot for work, so my fridge is relatively empty. And so my challenge is actually staying healthy on the road and trying to figure out like how to not, consume too many unhealthy things, or to, stay within a healthy weight range for myself, or what I consider. So that's the main challenge. And I would say that my go-to for that, from that end, I like to find poke whenever I can, because I can kind of control what's in it. I know that there's, fish, which is, healthy. There are a lot of healthy fats associated with that, and high in protein as well. I'm big on, trying to make sure that I have a good amount of protein intake. So that's really what I go for.
So final thing, as a gastroenterologist, everyone's all ears now. What are 3 things you would never do as a gastroenterologist?
Ooh, 3 things I would never do. Not get screened for colorectal cancer would definitely be one of them. I know that there's a lot of fear, especially in the US, where the primary screening method is colonoscopy. It is a procedure, but we're able to locate things and take them out and address them early on, which is the whole point of getting a colonoscopy, and you're asleep for it, so you won't feel a thing. The worst part of it is the prep, where you have to clean out your colon, where you have to drink a liquid and go to the bathroom several times. But that shouldn't deter you from getting screened. I know screening happens differently in the UK and elsewhere, but the key is to get screened, because that's really important. You don't want to wait for things to happen and it be too late. I guess since we've been talking about diet a lot, is ignore your diet and not eat a diverse diet. I think sticking to one thing is never good. I think diversifying and making sure that you're eating a balanced diet is super important. And the last thing I've got to think about that I would never do, I guess just generally speaking, something that we've been repeating over and over is taking supplements for no reason, and believing too much in the advice of people on the internet who have questionable credentials. So definitely seeking the help of a professional. I mean, I always welcome ideas. So if you have certain ideas that you come to me with, I can kind of validate whether or not I feel like that's a good idea or not a great idea. So yes, do your own research, but come to me, but make sure that you're, getting a solid opinion on it, because a lot of these, supplements are just not regulated the way that medications and procedures are. And so when you have an unregulated environment like that, who knows what could be put in there. And as we've seen, people come in, these are not without risk. So people do come into the hospital, not only because of delayed diagnoses, but because some of these supplements themselves could potentially be harmful and, can actually have a direct harm to other parts of the digestive system, like the liver. We've definitely seen many, many cases of people coming in with serious, irreversible sometimes liver conditions that, are a result of these supplements.
Austin, you are one of the good guys on social media fighting the good fight, and also one of my early inspirations for starting my own TikTok journey. So thank you for that. And also thank you for coming on this podcast and giving us the good gut science.
Thank you so much. I really appreciate it.
Thanks again to Dr. Austin Chiang. Next episode, we'll be finding out how you can rewire your brain, overcome mental health problems, break negativity cycles, phone addiction, bad habits, and a lot more with neuroscientist Nicole Vignola. Subscribe so you don't miss that and the weekly Dr. Karan Explores podcast. And I'll see you happy poopers next week.